my screen with you guys. Okay. Switch this to presentation mode so you can see. Okay, can you see my screen now?
Yeah.
Okay, so I'll go ahead and start by introducing myself. My name is Dr. Sierra Richard. I am currently a women's health and pediatric clinical pharmacist and the founder of Happy Farm Life. And today I'm just going to go over a little bit about what it's like to be a women's health pharmacist. Pharmacists in general have a different role than a lot of people think, but I want to talk about one that's even less heard of, and that is the women's health field. So today's objective, I'm going to discuss what a day, actually more like a night in the life of a women's health pediatric pharmacist looks like, because I'm a night shift pharmacist. I'm also going to explain the benefits of pharmacist involvement on patient care. So if you're not interested in being a pharmacist, what does that pharmacist bring to the table for the healthcare team, and how can you benefit from having a pharmacist help you? And then I'm also going to describe the role of a pharmacist within women's healthcare specifically, and why that's a growing field for pharmacist involvement. And then I'm going to do a review of an obstetrics patient case. So I know a lot of you are probably going to be viewing on YouTube, but the first question I wanted to ask, if anybody who is on here wants to chime in, what do you think a pharmacist does? When you think pharmacist, what do you think?
Like medicine and prescriptions, over the counter, maybe.
Yeah, so that's a common thought, is we think of pharmacist as the person who is gathering prescriptions. You know, you go to the doctor, you get a prescription, the pharmacist is who's filling that prescription, and they're helping with over-the-counter medications and things like that. Well, there's actually pharmacists in multiple settings. So you have the pharmacist that you're normally seeing maybe at Walmart or Walgreens or your local independent pharmacy. And those are kind of the pharmacists most people think of. A lot of things that I hear is people say, oh, I didn't realize pharmacists do more than just count pills. And that's not what we do at all. We're reviewing prescriptions to make sure they're safe and effective in that setting, but we also have pharmacists in hospitals and clinic settings, in industry, in academia. So you can find pharmacists in just about anywhere in the healthcare system. And so my job is in a hospital, which is probably a little bit different than what most people think of when they think of pharmacist. So my current job is I work as a pediatric and women's health clinical pharmacist. I do work the overnight shift. I work 7 days on, 7 days off, Monday through Sunday, 9 p.m. to 8 a.m., so 11-hour shifts. And during that time, I cover our entire hospital. We have around 100 beds. So I cover the emergency department, our general pediatrics floors, our maternal health and labor and delivery floors, as well as the neonatal intensive care unit, pediatric intensive care unit, and operating room. It's myself and one technician for the majority of that shift. I usually have help until 10 p.m. And then during the week, I'll have somebody come in at 6 a.m. Otherwise, I don't have anybody till 7:30 in the morning on the weekend. Since we don't have OR cases, I don't need quite as much help, or we don't have chemo or anything in the morning. So some of the things that I do is I verify medication orders. And what that means is anything that the doctor orders in the hospital, a pharmacist has to review it in order for it to go to a patient. There are some exceptions where overrides are available, such as the emergency room, where delays in care could be significant. Same thing for labor and delivery. If somebody's in a C-section, I don't need to verify it before they give a med. I'll go back and review it. So in case there was an issue with it, I can talk with the team and we can prevent that in the future, or discuss it with the patient if there's any interventions that need to happen. That's rarely the case in those situations, since it's pretty much only emergency meds. The team is very good with handling those. I also answer drug information questions. This is probably one of the biggest things that I do, and the ways I could contribute the most is the physician will call the pharmacist and ask for dosing information. They will ask us for side effect information if they think maybe a side effect is contributing to a patient's current status. They'll ask us about drug interactions, looking over the home meds, making sure everything is appropriate. We do also monitor therapeutic drug levels. What this means is there are certain medications that have a very narrow window where they're safe and effective. In some cases, if it's too low, it's not going to be effective, but if it's too high, it can cause toxicity. So pharmacists will monitor those blood drug levels, and we will adjust therapy based on the patient's renal function, liver function, and whatever the current level is. We also check the sterile and non-sterile compounds that technicians make, especially in the area that I am with pediatrics. We have to make a lot of patient-specific medications. So we have recipes that we mix up, compound those for our patients so they can have something that is weight-based for them. I also monitor any other technician activities. So we have medication stations throughout the hospital so nurses can easily access medications that they need. And I review those medications before the technicians deliver those, make sure everything's in date, the correct drug, concentration, those sorts of things. And then I also have a little bit of an additional role that most night pharmacists probably don't have. And that is because our hospital was running short on staff to review our women's health service patients during the day. And a lot of them also come in during the night. I don't know why babies love to come in the middle of the night and decide that 2 a.m. is when mom needs to show up at the hospital, but that's the way it is. And so I'm doing a lot of the admissions for our women's health service. So I complete the clinical chart reviews of those patients, and I'll talk a little bit about what goes into that, because that's a little bit more in-depth role for a pharmacist that maybe you wouldn't see in the outpatient setting. And then I also serve as a member of our rapid response team. So anytime there's a code blue, I will respond as well and cover kind of the medication side of things. So as far as the value of a pharmacist, we have doctorate level training. So all pharmacists in the United States, when they graduate, will have a doctorate of pharmacy degree. We are also trained thoroughly in evidence-based medicine. We have an entire course we go through, and it is something that's ingrained in every single one of our clinical rotations our last year of school, where we really learn how do we take research and studies and apply it to specific patients. We also have focused coursework in pharmacy and medication therapy, things that other providers don't get in their training because that's where our expertise is pharmacy, and that includes pharmacology, which is really the ins and outs of the drug, how the drug works, what we expect with it. Pharmaceutics, which is more of the drug delivery system. So we learn how medications are released whenever you have a patch. So we know if you can cut it or not, but we learn how that patch works. We learn how those pills dissolve and slowly release drug, or the different mechanisms of release. We talk about eye injections and things of that nature as well. Pharmacokinetics, which is really how the drug works in the body. We have pharmacotherapy, which is where we bring everything together, and as basically how do we treat a patient with medication. Toxicology, a big part of my job as a pediatric pharmacist, we get a lot of accidental ingestions. So knowing what we can do to treat those and what is safe and effective medication therapy to reverse any toxicology effects that we can. And then we're also taught about patient education and counseling. How do we take all of this complex information that we learn as a pharmacist and teach it to patients in a way that they understand? And the value of a pharmacist has been seen in many studies. And so some of the things that pharmacist involvement has been shown to help with is reducing hospital readmission rates. So whenever a pharmacist is involved, these patients are less likely to be discharged from the hospital and then come back with a complication from the same illness. Also, it's shown that patients have a better knowledge and understanding of medications when a pharmacist is involved in the education and understanding of their medications. It also increases patient adherence. Patients, once they understand and know their medications, they're more likely to take them. We've also seen a decrease in medication errors. That's something where one of those safety barriers in there. Pharmacists are there to really help physicians. We're not there to undermine them. We're not there to say that they've done anything wrong. We just realize that physicians, just like everybody else, are humans. And so what we're there to do is to say, hey, this looks a little bit different than what we normally do. Is that what you meant to do? And 9 times out of 10, when I make a call, the answer is no, that was an accident. That's not what I meant to do. And we're able to get it adjusted and changed. So that's one of those barriers that we are there for. We also have seen an increase in guideline-based therapies, which basically means when pharmacists are involved, we're more likely to follow what the evidence-based therapies is if there's a guideline available for that, such as like heart disease or diabetes. We've also seen a decrease in healthcare costs because we're using more of those guideline-based therapies and doing more of a stepwise approach with a pharmacist involved. And then just providing better patient outcomes, that teamwork and having that interdisciplinary team, and rather having one person make decisions, but having multiple people involved, has been shown across the board, whether it's with pharmacists, nursing, RTs, PTs, just having that interdisciplinary teamwork has really shown to improve patient outcomes. So in my job specifically being in women's health, we recently had a journal article that was published in one of our main journals, American Journal of Health System Pharmacists, back in December, that really highlighted the need for more pharmacists in this area. So number one, there was almost 3.8 million births in the United States in 2018. That's the most recent data that we have available from the CDC. And we also have seen in recent years maternal mortality on the rise. Part of that is because we see a rise in maternal age, but we also see that Black, Indigenous, and persons of color are affected at higher rates, regardless of education status or socioeconomic status. And we're also seeing an increase in these complicated pregnancies that are complicated by whether it's like a chronic disease the patient had before, such as heart disease or diabetes, or something that they developed during pregnancy, like preeclampsia or gestational diabetes. Unfortunately, pharmacists have really limited didactic and experiential training in pharmacy school. So there's not a class that really goes over a lot of the obstetric side of things. And there's less than 20 pharmacy residency programs with obstetrics rotations. I am at one of those locations, so there's not many available. And the ones that we have don't have tons of pharmacist involvement. Ours would be working with myself and then probably like an OB/GYN aside with me, since I'm not up on the floors. So it really just depends on the area. So pharmacist role in women's health, what we're seeing in the future and what that article talked about is where we hope for pharmacists to be in the future and moving forward. So being with the rounding team, being with the team of the OB/GYNs, the residents, the nurses that go around and check on these patients at night, be a part of that discussion of their medication therapy. One thing I do a lot is monitoring their home medications for clinical appropriateness. If the patient's inpatient, is that something that we still need to be on? There's certain medications we stop in case there needs to be any scans done or radiologic scans done. There's certain medications that aren't appropriate during labor and delivery that they may normally get because it might affect their blood sugar and things of that nature. So we look at those to make sure that certain things get stopped, but also things like their asthma medications or medications for other chronic illnesses that could worsen their outcomes during delivery or continued. Pharmacists can also be a part of contraceptive management and education. There's a lot of people going on, and while the physicians are perfectly capable of this, pharmacists is just another team member that can have that discussion, especially if they have a lot of questions or are curious. A pharmacist can sit down and have that talk with them, as well as discharge counseling on any other medications that they're going home on, and education of the use of medications during breastfeeding, as a lot of moms have made the decision to go home on that. So what medications are safe for pain, what medications are excreted in the breast milk, those sorts of questions can be answered by a pharmacist. We also can be involved in quality improvement. That's something that I'm involved with, even though I work on the night shift, is anytime I'm reading a guideline and I realize maybe we aren't meeting those standards or we don't have an order set to make it easy to meet those standards. We're sometimes working with IT to get an order set. So the physicians have to one click and they get everything that's in that guideline, and just trying to make it easier for them to make the right therapy choices based on the guidelines. I also come in for clinical recommendations in complicated patients. We've had patients that have treatment-resistant preeclampsia or have gestational diabetes that we're having trouble controlling their insulin. So pharmacists, such as myself, will be consulted and discuss those issues as well. And then vaccination monitoring is another thing I'm involved in, making sure that if the patient qualifies for any vaccines before that they leave, that they're at least discussed with the patient so they can make that decision on their own, but at least it's something that we can offer. So now I'm going to go through a typical patient case, this patient, I'm going to say, is probably one of my more standard types of patients that requires pharmacist intervention, because not all moms do. There's plenty of low intervention moms that I just kind of look over a glance, see that she's low intervention, make sure there isn't anything that we need to do, and then kind of move on. But this patient's one that I had to step in and get involved with. So this patient, LT, is a G4P1112, which sounds like gibberish, so let me explain. G4 is the number of pregnancies this person has had, including the current pregnancy. So she's been pregnant 4 times. One of the times she went to term. One of the times the patient was delivered preterm. One of the times there was either a elective or spontaneous abortion. A spontaneous abortion is also known as a miscarriage. And then that last number is the number of living children. So she has 2. And then you'll see in those last 2 numbers, we're missing a 4th baby, and that's because she has it inside of her. So once she delivers, we'll add to that number. She's currently 41 years old. She's 75 kilograms, and she is pregnant. She's currently 30 weeks and 2 days, so she's preterm. And she presented to our OB triage complaining of a very severe headache that was not relieved by ibuprofen or Tylenol, and leg swelling that's lasted about 3 days. She endorses positive fetal movement, so that means she can feel the baby is moving inside her, so she's not worried that the baby is not getting oxygen or something like that. And the patient has a history of preeclampsia in her last pregnancy, which was the preterm baby. Her blood pressure was 180 over 124. So if you know, 120 is where we're shooting for that upper number. So she was definitely on the high side. She has a heart rate of 110, and her urinalysis, so she did the lovely pee in a cup, and we found that it was positive for protein, which is another sign of preeclampsia. She had a group B strep swab done while she was there, and it came back positive. So we'll talk about what that means in a moment and why it's important. Her liver enzymes, so ALK Phos, AST, and ALT, which are all liver enzyme tests, were elevated, which is another sign of preeclampsia. Her renal function, though, was within normal limits, which is something we always check for medication-wise, so we know if her renal function's okay. Her liver enzymes were elevated, but not to a point I would change any medications because of it. And then she was rubella non-immune. So for all of our pregnant women, we'll check to see if they still have antibodies that keep them immune from rubella. If not, then they will need a vaccine that we'll talk about later if they opt into it. And then this patient also endorses that she's allergic to penicillin. She's had hives, itching, and swelling of the throat. So that's a pretty severe reaction. So we're going to want to avoid any penicillin or penicillin-related medications during her stay. So as a pharmacist, I don't diagnose. I can read a lot of these and figure out kind of what the diagnosis is before I read the chart. But this patient was very obvious from somebody who works in this patient population that she had preeclampsia. So that's our number one concern. It's the most serious, and we'll talk a little bit more about that later. She has was group B strep positive, rubella non-immune, and advanced maternal age. So any mother who is greater than 35 years of age will be considered advanced maternal age. The reason this is important, we know that these mothers are more likely to have complications. And so these are patients that I put on my high risk list to monitor closely while they're inpatient for any need for medication. They're more likely to need some sort of medication intervention than some of our other patients might need. So as a pharmacist, like I said, I do not diagnose. So I'm not going to go into a whole bunch about what the diagnosis looks like and how diagnosis is got, but more what I would do as a pharmacist after I've gotten these diagnoses. So the first thing I always do is I look at the patient's home medications. So this patient was on aspirin 81 milligrams daily and a prenatal vitamin. And you may be thinking, okay, why are we putting pregnant women on aspirin? So aspirin 81 milligrams is actually known to be helpful for preeclampsia prevention. And so we use this in medication, or use this in women who are considered high risk. For this patient, her advanced maternal age, as well as her past pregnancy history of having preeclampsia, that is why we are giving her aspirin, because if you have preeclampsia once, you're at high risk for getting it again. And she is on prenatal vitamins, which we recommend for everyone. So preeclampsia is more than high blood pressure. So I want to emphasize that. And while I'm not going to go into a lot of the diagnosis piece, I will say that preeclampsia is the elevated blood pressure. Usually you'll see positive protein in the urine, some sort of kidney or liver dysfunction or other end organ dysfunction. So it's not just that the blood pressure is elevated, but we have blood pressure elevation with some sort of organ dysfunction on top of that. The big concern with preeclampsia is it turning into eclampsia, which we'll talk about another medication to help prevent that in a moment. Eclampsia is where you have that high blood pressure, but you're also having seizure activity. It's very dangerous and could be fatal to moms. So we really want to prevent preeclampsia if we can, and definitely want to prevent eclampsia. Unfortunately, the only definitive treatment for preeclampsia is delivery. So in patients that are really, really preterm, we're doing whatever we can to get that blood pressure down, to get those other symptoms and end organ function monitored and under control so we can keep the baby in, but that's not always possible. In the case that it's risking mom or baby's life, then delivery may be decided on, even if she is very preterm. So high blood pressure medications recommended in pregnancy. Our most common medications, ACE inhibitors, and ARBs, as we like to call them, are contraindicated in pregnancy. So we cannot give those. So we have this lovely little mnemonic, he likes my neonate. And these are the 4 medications that we most commonly give, and they're the first line therapies with the best evidence to not have any issues in pregnancy. They're safe to give, and that's hydralazine, labetalol, methyldopa, and nifedipine. Unfortunately, nifedipine or methyldopa is the most effective medication, and it's currently not on the market because it's on drug shortage. There's a shortage of the raw materials to make it. So nifedipine and labetalol seem to be the 2 that I see used first. And then hydralazine is something that we'll do an add-on therapy. If a drip needs to be done, usually it's a nifedipine drip if we're having to give constant medication. So we just kind of have to go with whatever we have available and what's going to be best for this mom. So LT received labetalol 20 milligrams IV for 2 doses, and that was not effective at getting her blood pressure down. So she got labetalol 40 milligrams IV, 2 more doses. At that point, her blood pressure did stabilize, and we were able to convert her over to labetalol 100 milligrams PO BID. So the thing with labetalol is, as you can see, those doses look very different, and it's not well absorbed by mouth. So we have to give much higher doses to get the same effect or reasonably same dose as we would if we gave it through an IV form. The next thing that we give for these patients is IV magnesium sulfate. So this is the medication that we give to prevent that preeclampsia for becoming eclampsia. It has seizure prevention properties. It also helps if the baby is preterm, that it gives neuroprotection for the baby and actually reduces the risk of cerebral palsy, which can occur whenever there's preterm delivery. So in this case with this mom, it's actually doing 2 effects. It's helping prevent the seizures for mom, and it's also helping protect the baby. So we do 4 grams of the magnesium sulfate bolused over 30 minutes, and then they'll give a continuous infusion, 1 to 2 grams per hour, depending on how much of an effect that she needs. If they are really concerned about seizures or blood pressure is really uncontrolled, we'll do a higher dose. And then we'll continue that for at least 24 hours after delivery, because we have seen that continue it for 24 hours really does reduce that risk of seizures throughout and any other neuro complications in the mom. So that's pretty much it for the preeclampsia treatment that we were involved in. So next, let's go to the group B strep. So group B strep is a type of infection that is actually the deadliest neonatal infection. So these infections can occur due to maternal colonization in the genitourinary tract and the GI tract. The interesting thing about GBS is that having a group B strep colonization for the mom has no effect. It does not hurt her. Most women have it at some point in their life. At any given time, 20 to 30% of pregnant women are colonized with group B strep. because you have it one pregnancy doesn't mean you will have it the next pregnancy. It doesn't mean that when you're tested initially that you will never have it again. You may have it in a later pregnancy. And of those women who are colonized, 50% of these women will pass GBS onto the baby during delivery if they are not given antibiotics. And 1 to 2% of those babies will be infected if they are not given antibiotics, or if the mom's not given antibiotics. We typically recommend that we can get in at least 4 hours of antibiotics. So that's why it's important to know what mom's status is before she comes in, or we just assume that she is positive until we have confirmation otherwise, because the longer it is in, the more effective it is. Now, we will never, ever delay delivery. If baby is coming, whether it's 2 hours or 4 hours, we're not going to hold off delivery just because of this, but we do know that it's the most effective at 4 hours with a good amount of effect at 2. So if we can at least get 2 hours in, that drastically reduces it. 4 hours is the max benefit, but we'll keep it on until delivery. The preferred antibiotics is penicillin G. We'll do 5 million units one time, and then we'll wait 4 hours and follow with 3 million units every 4 hours after that. But if you remember, our patient is allergic to penicillin. So there are alternatives. Cefazolin is an alternative. It is in the same family as the penicillins. So we don't give that if the patient is a high risk of reaction. Then our 2 options are clindamycin and vancomycin. Clindamycin is preferred. It's not as broad spectrum and doesn't have as many toxicities as vancomycin. So it is preferred, but there is a lot of resistance just out in the world now because it's a pretty common medication that's given. So because of antibiotic resistance, we always require that patient to have some sort of sensitivity results to let us know that they are susceptible to clindamycin before we give it. So if we don't have that, we unfortunately have to go to vancomycin, which has some toxicities and needs pharmacist following because we will do drug levels on that medication, which is exactly what we ended up having to do for LT. So LT was positive for GBS during screening, was penicillin allergic, high risk of reaction, but they had not gotten sensitivity results on this patient. So we ended up having to give vancomycin. In our hospital, we have the ability, well, our residents have the ability and physicians have the ability to put in a pharmacy to dose order, which is basically a pharmacy consult where we will do all of the monitoring of the antibiotics while the patient is on it. Most of the time, these patients are not on antibiotics long term, so we never get to the point that we need a drug level. But if this patient were to have a change in renal function, then we might decide to get a level a little bit earlier or change her dosing regimen. So based on the American College of Obstetrics and Gynecology, the recommended dose of vancomycin is 20 mg per kg Q8 hours, and we did the math for her and it ended up being a nice even 1500 mgs every 8 hours. And so she ended up getting a couple doses of that while she was waiting to deliver. The next thing that pharmacists were involved in was the immunizations. And so we always like to look to see where they're at just so we have an idea. Tdap is recommended for all pregnancies, even if you have got one previously, even if it's been less than 10 years since your last Tdap. It's still recommended between 27 and 36 weeks for all pregnancies, and this patient did get it at 28-week appointment. The flu vaccine is recommended for all pregnancies during influenza season. This happened in the beginning of April, so LT did not receive it. It was not in season, and she had not gotten it previously. Now we're looking more at COVID-19 vaccine patients. My hospital is currently doing some trials and studies on the vaccine in pregnant women, and it's recommended for all pregnant women by the CDC now. That is a recent change in the past 2 days. It was, you can get it if you want it. Now we have enough data to say, yes, it is recommended in pregnancy. There's not been any concerns at this point for miscarriage, stillbirths, or any other pregnancy complications. So LT did not receive this because she was not eligible per our state criteria at her time of delivery. And then the MMR vaccine. So measles, mumps, rubella vaccine is recommended for all women who are non-immune after delivery. And the reason for that is it's a live vaccine. We do not recommend any live vaccines during pregnancy. And is given after pregnancy, specifically for the rubella or the whooping cough portion of it. Whooping cough is very, very risky for babies and infants. And so we want to make sure that mom is covered so there's a less of a chance to her to spread it to baby. I've unfortunately seen a few patients whose babies come in with whooping cough, and it is, I mean, just heartbreaking. They're there for days, have trouble breathing, on oxygen, coughing, and there's not really anything that we can do other than let it run its course. There's not a lot of treatment options for us to do. So something we definitely want to prevent and can be deadly to infants, even though if an adult got it, you have a little cough. And so LT did opt to receive her MMR vaccine on the day of discharge. So the patient case resulted, and after I left from my shift, she continued to have blood pressure instability over the next 24 hours and ended up getting a C-section. The infant was stable, but went ahead and took the baby to NICU for observation, and LT was able to discharge on postpartum day 4 and had no complications after her C-section. So do you guys have any questions at this point about the patient case?
Not really directed towards this case, but I actually was wondering if you could talk more about why you chose to become a pharmacist rather than, let's say, like a nurse or, physician.
Yeah. So let's talk about that one. That's a good one. So I really enjoyed healthcare and science when I was in high school, and I knew that I wanted to do something in the healthcare field, but I found out quickly. My brother one time cut his leg on a rock, and I freaked out more than he did. I don't like blood. I figured that out early on. So I was not going to do something where I was going to have to see or deal with a lot of blood. That's not my forte. I found in high school I really enjoyed chemistry. I actually competed in the International Science Fair in the chemistry section when I was a high school student, and chemistry was my thing. And so we had to take these quizzes in high school, like, what are you going to be when you grow up? You know, the career finders. And my first choice was pharmacist. I told my mom that. Next thing I knew, she had told the local pharmacist. I was from a real small town and they needed summer help. So 16-year-old me had a summer job working in the pharmacy, and I just fell in love with the profession. I loved the chemistry side of the medications and hearing and learning about the medications, as well as the patient interaction that you get. So you still get that opportunity to talk to patients and be involved in their care without having to deal with the blood. Minus a couple times where you had patients come in and they're like, I cut myself, what do I do? And you're like, not come to the pharmacy. We got them fixed up anyway, but that's kind of how I got started. And then as far as getting into where I am now, pharmacy has residencies just like medicine does. And so I ended up doing a residency in a children's hospital in Fort Worth, Texas, and then came back to where I am now. I was working there as an intern and came back to work as a full-time pharmacist. And while I was trained in pediatrics, I realized pretty quickly that women's health was the area of need since they didn't have anybody clinically following them at the time. And so I've kind of just jumped into the women's health side, and I really, really enjoy it. There's a lot more for pharmacists to do than I think, as I mentioned earlier, than people realized. So I have kind of jumped in that aspect because it was an area of need, but I also enjoy it greatly. There's a lot of similarities with the women's health side and pediatrics in the sense that both are considered vulnerable populations from the FDA, which means we don't have as much research on these populations as we do, your standard adult with diabetes. So a lot of what we're doing is off-label. A lot of what we're doing is interpreting very small studies and seeing, does this actually apply to the patient I'm taking care of? Thankfully, ACOG has some pretty good guidelines for things, but a lot of the information that they're providing us is, this is a limited study. This is the number of studies we have done, and we're just kind of combining what we have because we don't have a lot of information, unfortunately, in these populations. So I think that's another real benefit to having a pharmacist, is we can look at that data from the evidence-based medicine side of things and provide recommendations and just work alongside our team members and our physician team members to come up with the best option for the patient. So I've really enjoyed being a pharmacist. It's very different than I think a lot of other fields, especially doing what I do in a hospital. We're a little bit more hands off the patient. Depending on what you're doing, my role, because I'm there at night, nobody wants to talk to me about their medications at 2 a.m. So I don't see patients as much as I liked or as much as I did in residency. I spent a lot of time hands-on in residency working with patients, which was really fun, teaching a 5-year-old about their EpiPen, and also teaching mom while we're in there about their EpiPen and things like that, or how to use their inhaler, those sorts of things. So we're in a little bit different of a role in that sense. So we are very specialized in, we deal with medications in the treatment, and that's kind of our wheelhouse. But I think if you're somebody who really likes to dive deep into a topic and really get to know the nitty gritty details of drugs, that's definitely an area that you can get with pharmacist and being a pharmacist.
Okay, thank you so much. Yeah, I can definitely tell you're so passionate about this, and it's really great. It actually leads me to my next question. Like, how do you stay motivated? And just like, because being a pharmacist is like so difficult. Like, how do you want to do it every day, I guess?
Well, I love it so much that I do pharmacist stuff on my day off with my social media, which is how you guys found me. I think it comes down to the fact that I went into pharmacy because I loved it. I didn't go into pharmacy because it paid well, even though it does. I didn't go into pharmacy because I wanted the glory, which is something that pharmacists definitely don't get. Most people don't even realize we're looking at their meds and all the errors that we're stopping. I went into it because I really enjoyed learning about medications and drug therapy, and also knowing the impact I could have on patient lives when medication therapy is done correctly. And I think it comes down to doing whatever is something that you're passionate about. And I know that can be hard to find, but I feel like when you know, and it'll just kind of click for you. Um, so I recommend, doing things like this and learning from other professionals, doing shadowing in person whenever that's available again, to really find what keeps you going. And then also knowing when you need a break. I'm currently on a little bit of a social media break right now. I had been posting like every day for, I don't know, 6 months or something, or almost every day. And so I took a couple weeks off to just enjoy the sunshine. We have beautiful weather here right now. That is like summer-like weather here in Missouri at the moment. It's like 80s degrees. So we're just enjoying that right now. And that's okay too. You kind of sometimes have to take that step back and regroup, recharge. But for me, I just really enjoy what I'm learning about. I love my pediatric patients. I love my women's health patients. And I also know how many women would like to know more information about these medications, and being able to provide that for them, I think, is something I am extremely passionate about and want to help in any way that I can. I have all this information in my head, and it doesn't do any good if it's not given to the patient. So I think that's a real motivating factor to me, is knowing that if I am able to provide that information to somebody else, it can help them better their lives.
Great. Yeah, that's really great. I'm not sure if you can see the chat. There's a question about the case.
Oh, let me see. I think I have the chat pulled up. Did she use an epidural? I was not there during her delivery, but I believe that this patient actually had a spinal tap done instead of an epidural, which are both options for C-sections. It really just depends. I do not really get involved in the spinal tap because that's done in the OR, and pharmacists are not dealing with that. I fill we have like these, we call them epidural trays, but we have medication trays that I'll refill in the evenings that have all the medications for that. So it's bupivacaine, lidocaine, ropivacaine, fentanyl they can use for those. And so I refill all those medications, but I'm not involved in the decision. That's the anesthesiologist. We do make the epidurals when we have to give them. So epidurals usually contain fentanyl and ropivacaine, and then they contain just ropivacaine in certain cases where the patient either requests it or we're concerned about them using opioids, such as they have a history of abuse or those sorts of things. So we are involved in the epidurals a little bit more. I'm pretty sure this patient did a spinal tap though, because I didn't see an epidural on her profile when I went back to finish this case. So we wouldn't see the medications for the spinal tap like show up on her MAR. So I don't think she used an epidural. That's a great question. So the question that just came in was, how does working the night shift affect your day-to-day and social life? Well, COVID has also really screwed up the social life side of things. In general, things are starting to open up back again. My husband and I are both vaccinated now, fully vaccinated, which is exciting. And so that's going to probably play a bigger role. So my day to day, it's taken me a while to get used to it. I really love having 7 days off in a row. It's like a little vacation every other week, but it takes a while to adjust. So I've slowly learned the best ways to do that. I don't do a whole lot I don't like plan anything on my week that I work. Occasionally we'll have something where like my coworkers want to go out to eat and I'll go to eat with them. But usually they do that late in the afternoon so I can come. So like 5, 6 o'clock. So I'll be awake. Kind of my normal is I get off at 8. I'm usually trying to get in bed by like 9, 9:30 so I can wake up at like 4:35 in the evenings, eat dinner with my husband, try to get a workout in, 20 minutes max usually, and then go to work. And basically I don't have a social life during my work week, and anything I plan with family or friends is on my week off. Now that things are opening up and my family's vaccinated, I did get to go see my little cousins a couple weeks ago and went up there for Easter to spend time with my family. So I just find ways to, incorporate my social life on my week off. It does stink that I work every other weekend the way my 7 on 7 off works, but it's not affecting me too much thanks to the COVID life. During my week that I am off, I usually totally flip my schedule back to days. It's a gradual process. I usually like get off Monday morning. I do like a 3-hour-ish nap in the middle of the day and then wake up and then try to go back to sleep at a regular time Monday night, and then hope that that works. If not, I spent a lot of time napping on Tuesday. This week was a week where I spent a lot of time napping on Tuesday, but I'm fine now. I'm back to normal. So it's definitely an adjustment. And if you're somebody who had a lot of weekend plans, the 7 on 7 off life is not for you. But you learn to adjust. I think there's a lot of benefits to having the week off. Like my husband and I are able to plan trips and things that we couldn't do otherwise, that we're planning, the end of this year, that we hopefully will be able to travel more. And the other benefit is, like at the end of May, I'm doing a vacation and I'm going to end up getting 3 weeks off in a row because I'm taking my work week off and then I have my week on or my weeks off around it. So that's also a benefit that you get longer periods of time off when you take time off. So, you just kind of work around it.
I have another question.
Okay.
So, yeah. How do you like ensure that you're up to date with all this new research and just like the knowledge in the field in general?
That's definitely always a struggle. So I rely a lot on the organizations that I'm a part of to get my updates. So I get on the email update list for those organizations. ACOG is one of them, the American College of Obstetrics and Gynecology. Currently, I'm going through all of their guidelines so I can stay up to date. And then I also monitor every month to make sure that there's not been any updates that we need to address. And as far as the pediatrics go, there's a pediatrics organization that I'm a part of for pharmacy, and I get their email updates and we kind of monitor those as they come up. And the American Society of Health System Pharmacists get their emails and look those up. And then, just also with the COVID situation is honestly monitoring some of the news. And I get COVID updates too, and I'm a part of our state's COVID updates. They give us those emails as well. So it's a lot of sorting through emails, honestly, to see what's relevant for you. And so I use those. But when the news sends something out, I go look for the primary literature of whatever they're saying, because yeah, there's probably some new information out, but is it relevant? Is it actually a good study? So I'll clinically evaluate anything that I'm seeing too, especially when it comes to misinformation, because there's tons of that on social media. And so right now, the big one that we're hearing is the rumor going around that if you are a woman who menstruates and you're near somebody who got the vaccine can shed and cause menstrual problems to the person who's not vaccinated. And that's completely not true. The vaccine can't shed. So, we have to spend time reviewing where did this information come from and explaining why it's not relevant. So, um, it's kind of a mixture of the news, the emails from organizations, and then just going and looking for information too, especially if it's a more rare disease state that we don't deal with as much. I'll always do a literature search or review to see if there's any new information on it before I'll make a recommendation or a change. I also follow like the CDC. I got an email alert from them when they changed their STD guidelines recently for chlamydia and gonorrhea. So I was able to be like, okay, today they changed the guidelines, so we're going to change what we're doing. And, I came in and was able to help get that change implemented, for particular for our ER. So, those are just some ways to be kind of involved and aware. Also knowing when new guidelines are planned to come out. The CDC is usually pretty good about saying, we're planning to have this new guideline in this year. So you kind of know to keep an eye out for those things.
Thank you for answering.
Mm-hmm.
I'm not sure if you have like more slides, or do you want me to just like ask you another question? I'm not sure.
I only have a couple more things, and I was just going to go over what I do on social media. I've kind of talked about that a little bit. So I'll talk about that because that's the other side of my job. So basically I say I have like 2 full-time jobs. I work as the pharmacist and do that for 1 week. And then my week off, I do things like this where I do presentations and also do things on social media. So the big things that I like to focus on is like women's health medication education specifically. So medication adherence, birth control, medication use during pregnancy and lactation, vaccinations, and then serving as mentor to students, and then advocating for the profession of pharmacy and women in healthcare in general. It's something I've been very passionate about and really enjoy doing. So for anybody who is watching, who is interested in that or learning more about that, I'm on YouTube, Instagram, TikTok, and then I have a website blog as well. A lot of my blog information is from women. We have a blog called Wonder Woman Wednesday where these women talk about their experience. So I have some healthcare professionals, I have some patients that are healthcare professionals talking about women's health disease states on there. So it's been a really awesome opportunity to get to connect with those women, and also in some ways made me a better pharmacist from the empathy standpoint and learning what those patients go through to get a diagnosis and that sort of thing. So with that, if you do have any more questions, I'd be more than happy to answer.
Yeah, I actually have just one more question. So are there any aspects in pharmacy that you feel like that you don't enjoy or like need improvement in? And just like talk about that, I guess.
Yeah, absolutely. So right now, I think the biggest concern that I get questions about all the time is the job market in pharmacy. So a few years ago, there was a major need for pharmacists, especially in rural areas. And so there were multiple pharmacy schools that open, or a lot of the schools increased their enrollment. And so now we have a lot more pharmacists than expected job growth. Which is a very interesting situation to be in, especially whenever it was not that state when I started pharmacy school and it was when I got out. But what I have learned and what I feel like has helped me is I did not focus on the fact that we're supposed to be in this bad job market. I focused on the things that I could control because I can't control what the job market is. Obviously, I had to be aware of it, but I focused on the things that I could do to make myself a better candidate. So even if there was only a handful of jobs open, I would be able to get one of them. And so I focused on improving my clinical skills and school. So that meant going to volunteer events where we did blood pressure and diabetes screenings, and that included leaderships, positions that I got in school. I was a regional officer for the American Pharmacist Association. So those types of things were things that I focused on, doing research, just being involved in a job and having a job in pharmacy school and getting that practical work experience, just trying to do whatever I could to be hands-on. So that's one aspect that I think a lot of people are concerned about with pharmacy right now. I think it will be interesting to see what happens in the coming months. So currently there's a bill in the House of Representatives that would allow pharmacists to bill for their clinical services, which is something that we cannot do directly right now. And that would also open a lot of opportunities, I believe, for pharmacists and pharmacist involvement. It's not that we're asking to do anything that we aren't doing already. We're capable of doing that. We're just not able to bill for those services. So that has been a barrier also from implementing a lot of those services because pharmacists weren't able to do that. Other things that I've seen that are actually improving is payment models for pharmacies. Previously, there was a lot of I don't know a better word other than sketchy, slightly sketchy things going on, and pharmacists were actually losing money on a significant amount of prescriptions, which was making it hard for pharmacists to stay open, which is very bad because patients need their medications, right? So we've seen some legal changes in the past year that actually will make that better, hopefully moving forward. I would say pharmacy is a very stressful job. I mean, I would do 11-hour shifts for 7 days in a row, and that is mentally exhausting because I have to be on for a full 11 hours. If I am not paying close enough attention or if I have a mental lapse, it could be deadly for a patient. And so that is something that does weigh on you. The other thing is with my population, you sometimes are there for the happy days, when a baby is successfully born and mom, has a successful delivery, but we're also there for people's worst days where they have to say goodbye to their infant or their child. And you're a part of that code team and you are there when the physician tells them, I'm sorry, there's nothing else we can do. And that is very emotionally taxing. It was something that I struggled with, I would say, in residency because I worked in a large ER and I saw that frequently saw bad outcomes. And that's a difficult thing. And that's for any healthcare field. So learning how to cope with that can also be difficult. And just pharmacists showing their worth, I think, would be the other thing. A lot of people don't come to events like this and learn what pharmacists are doing. So sometimes people in your healthcare team don't know what benefits you can provide or how to best utilize the pharmacist skills. And so sometimes it takes a little bit of work to show what worth you can provide to the team in order to get that maximum benefit for patients.
Thanks for answering my questions. Thank you so much for coming. I loved your presentation. Your passion was just so evident. So thank you again.
You're welcome. Thank you so much for having me.
All right.
You too.